place your name and campus in the chat. Hopefully everyone is well. We still have about 45 seconds before we officially start, but if you would, place your name and campus in the chat. Just as a reminder, these sessions are recorded and they are viewed by the attendance administrators. Ensure that you're on camera during class time. There are some times that you might not be on camera. For example, if you have an issue, having to go to the restroom, make sure you place a message in the chat to myself. Do not send it out to everyone. Good evening and welcome to week 9.
Excuse me, Professor, I have a
Almost there.
question.
Mhm.
Have quiz, we have exam today.
We have quiz 5 today. Yes.
Okay, thank you.
Mhm. Yes, welcome to week 9. We missed you all last week. I know we have to take those holidays, but it just seems like we could do something to make up. But anywho, no fear. We have the week prior, we did go over our content. So that means this week we're ready. All right, so let's look at our modules and let's see where we're at. Emily did bring up a good point. Let's look and see where we're at and where we are going. You all should start, me go to the course room here. Start receiving information regarding your HESIs pretty soon if you have not already. Remember, it is campus specific. So if your classmate is saying something's occurring at their campus, first, hey, you go to that same campus. You might want to verify information with your campus deans. And that's going to be your best person to go to get those specifics. The HESIs for all of your courses are in, week 11. Most of the time, unless something changes, HESIs are not given during these late classes. So I know you've been had the same schedule for the term, but look at your week 11. Go ahead and find out as much information as you can about your HESI so that you can go ahead and start arranging for whatever it is that you need to arrange for during that week. Because they're generally not given this time of night, these late classes. Now, if you have some evening classes, they might offer that early evening, I put it like that. But these late classes, I haven't seen it where they're given this time of night. But you never know. But nevertheless, just put that on your to-do list to find out so that you can prepare for that. So yes, we are in week 9. So we have quiz 5 tonight. We have unit exam 3 on next week, which is week 10. Week 10 is like week 4. If you're taking more than one class, go ahead and be thinking about what that should look like for you. If you're having more than one class, more than likely you're going to have more than one exam on next week. Just depends on the day of the classes. It might be on the same day. So be thinking about what that needs to look like for you. In the event that you need an exam proctor on campus, remember the 72-hour notice because we have to find a person and a place that you can take that exam. So just be thinking about what works for you. In the event that you're needing an exam proctor on campus, it's not just this class, any class. Make sure you go ahead and send your professor the email, include your campus dean, because they're the one that's going to coordinate that. Include Dean Brown in it, and as well as the course lead for whatever course that is. For leadership, it is Dr. Mary Tenza. And like I said, probably the end of this week, but for sure next week, you should be receiving HESI information. Week 11, the HESI exam counts as your attendance for week 11. So we do not meet in week 11. The other thing about the HESI, remember also, they're not given this late, usually not given this late of the day. Also, remember these classes are Monday through Friday. So the HESI might not be given on the day of the week that you normally take your class. So I don't know what it looks like, but just be thinking about that. Be proactive and go ahead and start having that conversation with your campus dean so you all can be looking at what that's going to look like for you. And then, of course, week 12, we do meet briefly to look at our scores and the national score. So that's where we're at, and that is where we are going. All right, so let's move forward with our content here. let's see here. I found that new button inside of Kahoot. So let's try it out. And then we will move forward. I think we did. Was it learn or flashcards? Let me see. Was it learn? Study your own flashcards. Let me see. I think it's learn. Nope, it wasn't learn. Hold on. Yes, it's learn. Okay, let me share my screen here. And I'm going to try to be quiet. Myself and Dr. Fiat, we're going to be quiet and just let you all talk us through it. If you will come off mute and then give us the answer, and I'll select it and submit it, and we'll see if that is the correct answer. So let me share my screen here. Okay, so read through, and of course, these are not, all the way correct. So some words are left out because it's character count. So read through, and then try to answer based on what it's asking you about the concept. So this first one I'll read. Steps in the conflict resolution process. So the main concept will be the conflict resolution process. So then it wants us to identify all the parts, everything, all the different parts of it. So let you read through and tell me what to select.
Gather all the data.
Okay.
Define the problem.
Define the problem.
Evaluate all of them.
All of them.
Yeah.
Okay, is that our final answer? And let's see how we did. Okay. All right, let's see. Again, I'm gonna try to be quiet here. Oh, this one is asking, it's saying first step in the conflict resolution process. So again,
Define
the problem.
Define the problem.
So test taking tip. What is the main concept? Then put it into context. Now it's not asking you about all the steps, it's specifically asking you about the first step. So you all said define the problem?
It's gather
I would say gather the data.
Need to gather the data to define the problem.
Okay, so in the chat, I need you to put red or I'll put an R or yellow, because we have it split, and that's the one I'll select. So in the chat, R for red, which is gather all data, and then put a Y for yellow, define the problem. So going back to what it's asking us.
Because it say the first step.
First step in conflict resolution. Let me stop sharing. Let's see which one has the most. R or Y? Let's see. Looks like the R's have it. Let's see. I don't know. We'll see. Let's see here. Okay, so the R's is red. Unless okay, and that's correct. So let me go back. So why do we want to gather all the data before defining the problem?
You got to see what the problem is first before you can define the problem.
And collecting that data helps us to identify what the problem is. Exactly. Because remember, an example that we gave here was there's a complaint. So we might have to go back 3 shifts. We might have to get all of those. We might have to get all of the interviews. We might have to look at the schedule to see who was actually scheduled, who was assigned to who. Even though a person says, hey, this is what happened and I want to file a complaint. But sometimes what they're saying is really not the problem. So gathering all that information helps us to really define the problem. So the first step is gathering the data. All right. Positive feedback for employees include
encourage personal growth.
Yellow.
Blue.
Okay.
Offer prices in measurable terms.
Above.
Yeah.
All above.
Okay. So
Use the effort.
Okay. So what's the opposite of positive?
Negative. Negative.
Okay. So there's a difference. Again, identify what the concept is and then answer what it's asking you. So the main concept here is what?
The feedback for the employee, good feedback.
Okay. Not just feedback, but positive feedback. Then what did the question ask you to do to identify what?
For employees include, but the maintain an open door policy is not a positive feedback.
That's not positive? Take it off.
For me, no.
Okay.
I will
So,
say only blue for me. I don't know. Maybe I'm wrong.
okay, we'll see. So this right here says include. So we're looking for things that are true about positive feedback or things that are false about positive feedback. If you don't like the words true or false, correct or incorrect. So what are we looking for? Things that are true or false about positive feedback. It says include.
True.
Things that are true.
Okay.
True things.
True or either correct. So we are going with notice their efforts, encourage personal growth, offer praise in measurable terms, and we're saying no, don't maintain the open door policy. Let's see.
No, we maintain it.
Yes, because we don't. Because what's the opposite of maintaining an open door policy? Closed door policy.
Closed.
Is that negative or positive?
Negative.
That would be negative. So we do want to maintain an open door policy. Okay. Is this the same one? Positive feedback. Oh no, this is not the same one. What's this one? What's the answer?
The maintain closed door policy.
Okay, so she's identified the concept. Let's go back to it. It says does not include. So this time we're looking for things that did not match or that were false about positive feedback. So we just said an open door policy is what we wanted. So this right here says does not include. So another test taking tip, identify what they're asking you about the concept. Words like all, but, and, does not, it changes the way you were answered. Okay.
Red.
Red, yeah.
Red.
Red.
Okay, and submit. Okay. All right.
Hey, you're back.
What color did you say, Emily?
All of them.
Okay. Do we agree? Not hearing any opposition, so. Okay, let's go back to it. It says ineffective delegation. So in order, you have to know your concepts. Remember, what is delegation? So in order for us to be able to delegate correctly or effective, what are those things that we have to do? Then this question asks you about ineffective delegation. So you have to know what delegation is and all those different components in order to be able to say, nope, this is ineffective. So make sure that if you know what the concept is, if they ask you a negative question about it, then you should be able to answer because you want to see, does it match or is it correct? Okay. So I'm not going to say, because I think the next one is, no. What I was going to say is, if this was asking you, if the IN wasn't there, this changes this whole question. Effective delegation. So that's another one of those test taking tips. Remember these. And, but, all, IN changes this whole question. Okay?
False.
False.
So now we're taking what we know about delegation. You have to know the concept. Now we're taking it and applying it to a situation. Okay? So you're saying this is false. Okay? So why is this false? False, wrong, incorrect. Why is this incorrect or wrong about delegation?
It say
Because it's
outside
saying
of your
outside
scope
of your scope of
practice.
Your
practice.
scope of practice.
Exactly. Remember that Nurse Practice Act. It's our to-do list. It's those things that we can lawfully do, that we can do within whatever state that we are licensed in. And it says this one word says outside. That changed that whole scenario there. Okay.
False.
False.
Why would this be false?
Because the person needs to assess
It
them
say
first.
before.
We're assessing for what?
You
What's-
need to assess first the patient before you decide who you're gonna give the task.
Okay, and determine whether or not they're what or versus what.
Stable.
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 Got
Stable.
it. Okay. So can we delegate? Another test taking tip. Read the question. You may want to paraphrase, put it so that you can understand it better, but don't change what it's saying. So is this appropriate for delegation? So another way of paraphrasing this is, well, can I delegate this to a UAP or unlicensed personnel?
No.
No.
False.
Okay. Why can't I delegate it to unlicensed personnel? What are we asking that unlicensed personnel to do?
Something that is under the scope of their practice.
Which is
Some-
what?
Assess.
Or
Teaching,
A
counseling,
teach brief
Yeah,
or
like
advice
teacher.
to a patient.
because facilitate, tomato, because we see the word facilitate. Well, what is facilitate? They're discussing, they're leading, they
Give them
are giving
they need.
instructions.
Mhm.
Go ahead. Well, just
No, I was saying giving all the information they need to process.
exactly. So they're in there doing this counseling session with the patient. So they're outside of their scope of practice. So tomato. Well, what is the word facilitate? What is that? Okay, well, that's teaching, demonstrating, counseling. Nope, can't do it. Okay.
True.
Yes.
So yes,
True.
true, correct. All those mean the same thing. Okay.
Yes. And CNA can do it. No. LPM.
We're saying true or false. I think I heard both. But where we going with?
Oh, I'm sorry. I thought was on mute. I was thinking all loud.
Thinking out loud.
True.
And then
True. Yeah, it
True.
is.
okay. So test taking tip. We make sure that no one's in the room, that you're not talking to anybody else, but sometimes you do have to read things more than once and out loud and process it out loud in order to select that correct answer. So as long as we know no one's in the room with you, you can, read it. You're encouraged to read it out loud, the question and the answer. Okay. What we got?
True.
Okay. Why is it true?
Because they're LPN.
Okay. So this
They're
person is their
no.
license and is on our to-do list. Is in that Nurse Practice Act. Is in those things that we can lawfully do.
All of them.
Is that a final answer? Is that the final answer?
Yeah. Right.
Is it important that this patient is stable versus unstable? Is it important that we communicate and talk about what needs to be done so the instructions, the directions are clear? Is it appropriate to make sure this person is licensed, unlicensed? And at the end of the day, does it relieve us of our duty, even though we've delegated things? Does it relieve us of our duty, even though we've checked all the delegation tasks, rights of delegation? Or are we still responsible?
If we delegate at the end, we are
We're still
responsible for the
responsible.
task we assign.
Got it. We're still responsible. Okay.
And this one, all of them too.
Okay. So this one is just like the previous question we had. It asked about what was the first question? But it gives you a scenario. So this one's applying what we know. So don't get tripped up because you see a scenario. Long-term care setting. Okay, well, it's appropriate for us to be a leader in a long-term care setting. So it doesn't change that we still need to have a certain skill set in order to be that effective leader.
True.
Is that our final answer? Okay. And so remember the charge nurse, they're the ones that's overseeing the team. So they more than likely going to have less patients than the others, and they have additional tasks as that charge nurse. And so that does free them up in order to get those other tasks completed that they cannot delegate to anyone else. So we're going home and Nurse Nancy is coming on. What should we tell the nurses coming on? What information should be included?
New orders, patient be no new problem, new orders.
All of them.
All of them.
All of them.
Okay.
Yes.
Why is
You're right.
it necessary? What is this PRN medication? What is that all about?
As needed.
So you could know when the last PRN medication was given.
Okay, so give me an example of a medication.
Like Tylenol.
Tylenol, we gave it for pain, fever. So, and it's important that nurse know that when we gave it, because what if they check that temperature in 4 hours and they still have a fever? They're still febrile. What happens? What should happen?
They should check and see the last medication was given before they give anything else.
Mm-hmm. And if the medication is within the time frame, more than likely the nurse will do what?
Give them the medicine.
Okay. So it's important to know that, well, hey, this person received this because they had this going on. Blood pressure was elevated. Glucose was high. We had to give them extra insulin, whatever the situation is. Then we need to follow up to see if what we did, the intervention, did it help? Was the goal met? Does this person still have a fever? All right, let's see. How did we do? Okay. All right. Was that it? Okay. So since we got all of them correct except one. All right. So this time I'm going to be quiet. And I am just going to, everyone can participate because I want everyone to log in. Everybody. Let's see. Can I find it here? Are there any questions about any concepts that we went over before we start? Because I promise you I'm going to be quiet on this when we actually play this one. Uh-oh. Okay. So go to Kahoot and log in at least with your initials. You don't have to put your whole name. I'm going to share my screen here. And just one moment. So check your mics, make sure that you're on mute, because for this one, we will not share answers. We will not discuss it. It's everybody for themselves. So make sure you're on mute. And just a reminder, these sessions are recorded. So at a minimum, log in with at least your initials. And I'm going to put myself on mute too, so I won't be tempted to say anything. Everyone can take part. Let's see what microphone that there is. Let me just turn that off. So some things that I did see were just think about when you go to clinical. Remember your skills checkoff sheet. Remember in the skills lab, those skills that you practice, that you have to check off on, and that you are actually performing when you go to clinical. Those are things that you can do. So if it says, look for those keywords like scheduled or that's to be implemented, those are the skills that you can do or expect to do. If there, what was another thing? So the answer choice is partially correct. You know, you get to read the answer choice. Well, okay, well, this part is correct, but then the rest of the answer choice isn't correct. We don't want to select that answer choice because remember, it has to be all the way correct. So make sure that you're reading through and selecting the correct answer choice that you were intending to correct. Select. So let me pause here. Let me get our quiz ready. We're gonna go ahead and take our quiz now. So just give me a few minutes. Do not click on the quiz because you can't see it yet. It has not been published. We will place our passwords in the chat. So of course, if you're in my class, look for password that's from me. If you're in Dr. Friot's class, look for the password that's from her. So give us a few minutes to get it together here. So Dr. Friot students, please don't start yet because I'm not ready yet. So hold on because we don't want any interruptions. So give me just about 2 more minutes. 2 more minutes. Don't start. It's been published, but hold on. We want you to take that quiz without any interruptions. So just give me a few minutes here.
I need to buy a new one. It broke today.
Hey, remember you're not on mute. Check your buttons. Make sure these sessions are recorded. Okay, hold on one moment. I'm putting a little password in. Doo-doo-doo-doo. Making sure my time frame is correct. Okay, so all right, so don't start just yet, but click refresh and see if you can actually see the quiz. Look for it in the grade book and or on modules. It's in either or should be in either one of those places. And then, so you do have the 15 minutes to take the quiz. In the event that you don't start just yet, in the event that you finish before the 15 minutes is up, feel free to, turn your camera off, but make sure that you're back on camera at the time we will place in the chat. The password has been placed in the chat for my class. Hit refresh We may have to log back out of Canvas and log back in. So hold on just a minute. You all don't start because we want you to take the quiz uninterrupted. Hit refresh or either log back, log out, and log back in. Okay, if there is a question, don't start the quiz yet. If there's a question during the quiz, make sure that you place the question in the chat. Do not come off of mute. Wait on a response. We're slowly responding, just for my class, I put my code in for my class. If Dr. Freehouse didn't give you a code, that probably isn't one. Okay. And so if you have a question, don't come off mute. Wait for our response. So don't click yet. So we clear. The code that I put is for my students. And then Dr. Freehouse said there's not a code. Okay. All right. So I'm gonna go on mute. Everybody's on mute. And you can go ahead and start. Everybody can start. Okay, so it didn't take us the entire time to take the quiz. So if you would come on back. Come on back on camera because we do want to make sure we go over everything. And so we're almost at the top of or the bottom of our first hour. So what we're going to do is send you a little activity. Let me save it. Doo-doo-doo-doo. So since we're really close to the to our first break, we'll just do the first. We should have enough time to do the first two slides together, so I won't send it to you just yet. So let me share my screen here. So Nurse Danny and Lacey, they need our assistance. And remember, this is not any new information. It's same information. It is just presented in a different way because, you know, we all have these different learning styles and we want to just mix it up a little bit. Okay, so let me do my slideshow here from the beginning. So we have Nurse Danny and Lacey here. They're reviewing content on the theorists for a certification exam. We have an exam to take. So we need to assist these two nurses on information regarding the theorists. I think the theorist is where, you know, we kind of have a more challenging time or the content we need to make sure that we just take it out and just look at it on its own. So what should the nurse know? What should we be telling Danny and Lacey about the following? So you will have these slides. We're just going to do the first one together here. So Maslow's hierarchy of needs. So I'm going to go ahead and put myself on mute and give you a timer. I want everyone in the chat to respond with a one-liner, two-liners. Put it into your own words. What is this Maslow's hierarchy of needs? What does it do for a person? Give me you can do a summary, like summarize what does Maslow's hierarchy of needs, what does it mean? You can even list the levels. When we talk about Maslow's hierarchy of needs, what does it mean to you? What comes to mind? So I'm going to put a timer on, place your response in the chat and send it out to everyone. Give us a timer here. Give you a minute and 30 seconds. And then we will read and share out here if I can get to my timer. So the task at hand is placing in the chat a one-liner or two-liners. You can do two. You can list the different parts. You know, what is this? What is mass? What's behind this hierarchy of needs? Do I stay on one level? Do I master one level? Do I go up to is it an automatic? Did I go to the next level? Okay, y'all, I'm trying to find this time. Here it is right here. Okay, minute and 30 seconds. So the task at hand is, let me just tell you again, you're responding in the chat. Send the message out to everyone. Paraphrase, give us, if you were teaching someone or having a discussion with someone, what would you tell them about the Maslow's hierarchy of needs? All right, and start. Minute and 30 seconds. Place your responses in the chat. Okay, 50 seconds left. Again, the task is respond in the chat, send it out to everyone. Tell us, what do you think? What do you know? Maslow's hierarchy of needs. Why is it needed? Are there levels? What are the levels? If we achieve one level, do we stay on that level? What is it? What's important for someone to know about Maslow's hierarchy of needs? Okay, so let's look in the chat and let's see what did we do here. That's what did we share? So it can be used as a tool to assess whether the patient falls as a priority. So we do have priority questions. What's most important? What should be done first? Think about those priority questions, the way that they ask you that. So we're saying that knowing Maslow's hierarchy of needs helps us to put things into priority when we're trying to make a selection or trying to determine which of these steps that we should take first. Because when you see those types of scenarios, more than likely, we can do all of the answer choices, but priority, Maslow's hierarchy of needs helps us to do that. Because what's on that bottom layer? Let's see, physiological. So if a person's doesn't have anywhere to stay, a storm just came, there's no shelter. So the person's not worried about all that other stuff in the triangle. We're trying to get a safe place to stay. If the person is having a problem with gas exchange, those are going to be the priority things that we're going to select if we're trying to determine. Okay, Maslow's prioritized care using the needs basics. Okay, level needs can be met first, the first level. Okay, all right, human needs that are in order based off of priority. Yes. All right. So if I move up to the first level, second level, I move up to the third level, is it an automatic that I stay on that level? Or do my circumstances, do life journeys, do weather, do the economy, do illnesses, will I go up and down that triangle?
You'll go up and down the triangle.
Okay. And so the example that I just gave about the storm coming, I don't have shelter, but I did have shelter. So because I don't, that creates or causes me to find shelter. So that stirs something up. And whether or not I seek shelter from the homeless shelter, a friend, family, or if it wasn't a storm, what if it's a storm and then I've got my, the assistance, my insurance money, and then I'm ready to rebuild. It's still either scenario, it still creates that tension or that want or that need for me to find shelter. So those things on that bottom layer, food, water, shelter. If those things are missing, even at one point in time, that wasn't an issue for me, but now it is. So that patient or that person, me, whomever, will try to get those basic needs met. So we can go up and down that triangle. It's fluid. It's called life. It's called that journey through life. So it doesn't mean that if you achieve a high level, that you stay on that level. All right, so now we're at the top of our first hour. We will take a 5-minute break. Make sure that you can turn your cameras off. Make sure that you're on mute. Return in 5. All right, so come on back, and just as a reminder, these sessions are recorded and they are viewed by the attendance administrator. So just keep that in mind. Another thing that I did forget to say was make sure that your name it appears on the screen as it appears on Fortis's roster. So, if you're logged in on someone else's device, make sure that you go in and change your name, and make sure that you place your name and campus in the chat as well. All right, so we're going to finish our activity that we had started, and we're going to put you into groups. And it's just a random thing. So someone in the group, everyone doesn't have to pull it up. I'm sending it to your email, your Canvas mail. And so hopefully, I know there should be at least 4 people in a group. So you should, I'm not sure who that is that's not on mute. Check your mics, you all. Just be responsive. Make sure that you're on mute. We don't want to see or hear anything that we're not supposed to. Remember, these sessions are recorded. And so hopefully you'll end up in a group with my students. If not, just put a message in the chat and I'll just move you in another group. But you should end up in a group with someone from my class that will have access to the activity. This is nothing that is firm. It's just something that I just created so that we can look at these theories, because that's usually one of the topics that we kind of need to spend a little bit more time on. All right, so I'm going to open up the breakout rooms. There should be at least 4 people in the breakout room, someone in the breakout. Everyone didn't have to open it up. But again, we are talking to Nurse Danny and Nurse Lacey, and they're just discussing the theory. So when we come back, we're going to share out. I'm going to call in the groups to share out information about, let's see, it's 40 of us in here. So yeah, 10 groups would be good. What's on the slide. All right, so we'll give you their 8 slides. So we'll give you about 7 minutes. Shouldn't take that long because all this is information that we're reviewing. So accept the invitation to go to the breakout room. Go to your Canvas mail and it just says activity. And let's discuss. We'll see you in 7 minutes. And I will circulate to the rooms just to hear your conversation. Again, it is being recorded. Okay. Okay, so someone pull up the, someone's here in my class. I have what, 2, at least 1 person here. So you can share your screen and we're just discussing the theorists. And then we're going to share out. Let me put my timer on. It's in your Canvas mail. Then 1 person can actually share. And you all just discuss it and be ready to share out.
That one it says, the next one it says discuss Maslow's hierarchy.
Okay, do we have anyone here that's in my class? And we'll get your names. No one? How did that happen? So let me move you out to another room. I thought, or maybe I should have made the room smaller. Let's see here. Just gonna shift you to a room. Ariel,
you-
you have on Zoom, you have that little button that says share. But if this is working for you all, that's fine.
where?
So on my screen, it is like go to your Zoom screen.
Oh,
It,
on my laptop it doesn't work because there's not enough space. So that's why I
okay.
was doing it like this, but I don't know if everybody can see that. I'm trying. Sorry.
Yes, but it's just sideways. Turn it back the other way. Okay. Yeah, I can see it. It's just yeah, there we go.
Because we're just going over it. So
Okay.
What are we supposed to be discussing? Like the questions you asked.
What's on the slide? Each slide has a theorist on there, and it has some specific information that you need to know. So you're going to paraphrase and put it into your own words. You're supposed to be hearing each other, listening to each other, and then sharing. And that way, you're more apt to remember and understand no matter what the scenario is in the question that you're going to receive. So you want to put it into your own words. What do you remember? You all share what your understanding of generic is when we're talking about linear and professional. What does that mean? Because the more times you hear it and discuss it in different ways, you're more apt to remember it and be able to understand it no matter how the question comes to you or what the scenario is.
So which slide are the one that we're supposed to work on? The whole thing or
The
just
whole,
the number?
the whole thing.
Oh.
Yes, yes. And so when we come back, we'll let you share out as groups, based on, we're gonna hopefully we'll spin the wheel. We might not have enough time to spin the wheel. But yes, so because we need to know it all. This is our last week. So make sure you look at all the theories. What do you remember about Rosenstock? What helps you remember? What is this health belief theory? So share your thoughts and how you remember what that means. Give an example if you can.
Dorothea.
That one is the
Self-care deficit or nursing system.
individuals are inherently capable for caring for themselves and managing their health, but when they face limitations, a self-care deficit arises requiring nursing interventions.
Okay.
So practices, individuals will perform like they can maintain their health and well-being.
Everyone should be back in 30 seconds here. I caught myself mixing it up so that it would be at least have one person from the room from my class in it, but it didn't work out that way. So I did have to move some of you all around. But we move forward, we pivot and keep on moving. So let me hear from you. I think we have everyone back. Let's see. Yeah, I think I'm back. All right, so let's see. Let's look at our slide here. So we started off before the break talking about Maslow's hierarchy of needs. And it's important to know that, we have those different levels. And then, just depends on what's going on. We may go up and down the different levels on that triangle, the hierarchy. Another thing about Maslow is that it helps us to decide, what is priority when we're trying to figure out what should be done right now. There's a lot of things that we could choose to do, but if we're in the situation where where there's some type of unmet need, Maslow's theory, this, so to speak, creates this tension or this drive or this need that motivates us to respond in a way to try to fix the problem or the need. So Maslow was known for that. It helps us to think in priority. Okay, so let me share. Let's see what we got for our next slide. And then we're going to spin the wheel here. And I want to hear from you. I know our groups 9 and 10 were really large, so we shouldn't have a problem sharing out. Okay, so the next slide was trying to get it pulled up here. Lineager, what if you had to give us one word, what would that one word be to describe what Lineager considers or think about mostly? What does she think about or consider?
Culture.
Culture. Okay. So now let's talk about, what would that look like? We're in taking care of our patients. First, we need to do what with ourselves? Identify what about ourselves? What our own beliefs. We need to identify what our own beliefs are, and then also what are the beliefs of our patients, because we do want to include that in their care. In the event that it's not going to cause us any harm or them any harm, we do want to acknowledge those cultural beliefs and, include them in the care. Because remember, we have that partnership because it's the patient that's receiving the care, and so we want them to have say-so input, because we don't want to just write them down as being non-compliant or not wanting to do. What is it that, we need that will help you, with this process of whatever is going on with you right now? What is it that you need? Do you need to talk to a person of faith? Do we need your family member here? Have you identified? Do you have in this culture care also, you can bring in, we talked about those DNR, the do not resuscitate orders and those things. If they, based on their belief, they have these orders, these legal documents that we should follow, and it's part of their care. Anyone else want to add anything about lineage, that one word, culture? We need to be culturally competent nurses. What else did you all discuss about? And this is any group. Lineage. Nothing else? Okay, culture. What about here? When we say preservation or maintenance? Let's see, which group? Let me go to my little wheel here. Let me hear from you. Spin the wheel here. Okay, so this is group 8. Who was in group 8? You don't know what group you were in. Let me tell you. Billingsley, Gonzalez, Pamela, and DeVille. Tell us about What does it mean about cultural care and preservation or maintenance? You all didn't discuss this. Yeah, you all didn't get to this slide. Did any group get to this slide? It was the third or fourth slide.
My
Are you
group, no, we didn't discuss that.
Are you asking us individually or for group wide?
You can go. I asked the group, but no group. That group didn't discuss this slide. So the next group, just go ahead. I'm not gonna spin the wheel.
Well,
Just
you didn't tell us what slide we were supposed to do. So under our assumption, we did like slide 8 because we were group 8.
okay. So you're putting yourself down for slide 8. We got you. We'll get to you. All right. So another group.
Would
Okay.
it
You
be
said
like
it. You
aiding?
said it.
Would
Okay,
it be
go ahead.
like aiding clients and like maintaining their beneficial cultural practices?
Yes, that's exactly what it is. It's saying the same thing that I just said. The other slide and this slide really are saying the same thing. This one's just being a little bit more specific. Yes, including those practices in there. Even with this accommodation and negotiation. So, what was I think we had on a quiz question, a person or exam question. A person didn't want something to be removed. I don't know, but we left it there because it wasn't harmful to them. But then if you have, I know like meal trays, they have to, in the long-term care facilities, they have to remove those items. Like for example, the person wants to keep their milk, they don't need to leave it there because we don't want to accommodate that because that's going to put them at harm because that milk has to be at a certain temperature. But if something like water or tea, we can't accommodate that because part of their culture might be that I can't eat or drink this before a certain time or at a certain time. So we do want to incorporate that in there. Now tell me about this repattern or restructuring. What is that talking about?
helping patients modify harmful cultural practice while respecting their cultural values.
Okay.
Sometimes, for example, the patient, some cultures make herbal remedies, for example,
Mm-hmm.
and then we try to avoid that, but helping them to modify that kind of culture value with respect, obviously.
Okay. So what
Explain
they're
them.
doing may not be working. So we want to repattern or restructure. So this is where we reinforce that teaching. Well, hey, I do understand that this is what you value as part of your culture, and this is what you do. And that may be where that consultation with that physician or that dietitian. Well, hey, this is what your numbers look like. For example, a blood pressure number. Your blood pressure is still high. Your glucose is still high. And so we may want to show them those numbers, not us per se, but the dietitian or the healthcare provider. And so that they can see, well, hey, you might want to still do that, but we need to also add maybe this medication in or some other, it could be pharmacologic or non-pharmacologic intervention. But we want to make sure that they are aware of what they're doing is based on the documentation there's not any improvement. And so we have to reinforce that. Good. Thank you. All right. So let's go to the next one here. Slide 5. Let's see. Let's see. Who was group? Let's see. Miss Campbell, Boyd, Berry, Revis, Tipton, Wissett, Fields, group 9. Someone from the group to walk us through these phases. What is going on?
The orientation
The
phase, you can recognize the problems. Identification is where you identify the client understands the situation and responds to the nurse. Exploitation, client depends on the nurse, and resolution, dependent behavior, therapeutic relationship ends. That's all I have written down for it.
And then resolution, I have dependent behavior is given up and therapeutic relationship ends.
Okay, so we're clipping their wings or they're clipping our wings. They no longer need us. But during this orientation phase, we're trying to get them to like gain better understanding or grasp what's really going on. Then this identification stage. Tell me again what happens during this stage. The light bulb comes on. Tell me what you all just say about identification.
Make sure like the client understands the situation.
That's not what you said. What did you say before? Tell me what you said before. Or who was that? Was that you, Tipton, that said gave us a definition?
No, that's what
Client
I said.
understands the situation and responds to nurse providing help.
Okay. So now the light bulb, so to speak, comes on. I realize, okay, this nurse is here to help. The information they're giving me. Oh, okay, this is what I need to manage or to heal this broken bone or to manage this disease process or whatever. Okay. Oh, okay. Now tell me about the exploitation phase. What's going on now? They haven't clipped our wings yet. They haven't left us. What's going on during this phase? Tell me again.
Client begins to depend on the nurse and helps and uses help offered.
Okay. So it's like, okay, well, then they realize that we really are there for their best interest. We're really there for them. And so they're receptive to that reinforcement of that teaching and everything. And then they realize, well, hey, I got it. I understand it. Thank you so much. And, I'll call you if I need you. That's that resolution. Anybody want to add anything else from any group? Want to add anything about how you remember or what's your understanding of these phases? Okay, hearing none, we'll move on. Tell us about this self-care deficit theory. Forum. You all
It's a
mighty.
goal that is directed towards a safer environment for health, life, and well-being.
Okay. Anyone else want to add anything?
The
When the
client,
patient is not able to perform their self-care, bathe, a shower, dress, that's called, the deficit for self-care.
Okay. Who else was talking? Come on.
they want the patient to be able to provide as much care possible on their own with minimum help from the nurse,
Why is that?
so they could live on their own and take care of themselves.
So they can maintain some independency.
Exactly, because we do want to get them back as closest to optimal as closest to their baseline as possible. And remember, it depends on that setting. We're in that hospital setting. We're there 24/7. In a long-term care facility or skilled nursing facility, we're there 365, 24 hours a day as well. But as they start to transition, let me back up. There should be communication between if as a patient move from one setting to the next, for example, from hospital to skilled nursing facility or from hospital to home, back to the home, and they're getting that home help. There should be communication between the healthcare professionals so that care can be identified, the level of care, resources, and all of that. And then once that patient gets to that home, they're back there by themselves. We just come in maybe on Mondays and Tuesdays or Monday, Wednesdays, and Friday, but we're not there. So we do want them as independent as possible. All right. Rosenstock, health belief. What's going on here? Moreland Smith, Ganga, Ellen, Igandu, and Abraham. You all tell us. Someone from that group. What is Rosenstock? What is it? What does it say? What is it about this theory?
It's trying to explain why a person will or won't take action to prevent or detect illness.
Exactly. If I don't believe, if the patient does not believe, or if they do believe, we go into a community and we're trying to implement a intervention. I mean, it's the best intervention for whatever we're going in there for. But if that community, if that person does not believe that it's beneficial, or if they do believe, then you won't have any issues with implementing that intervention. But if they don't believe, then it's just something that you have for them that they're not going to be receptive to. All right, group A. Who was that? Put yourself down for slide 8. I'm going to be quiet here. Critical thinking. Come on, group A.
That was me. I mean, we just talked about what's on the slide. Well, our classmate who is in your class, she described what was on the slide, and we just talked about it.
Please share what you
It
talked
kind of
about.
is self-explanatory because it gives like examples underneath each.
Yeah, basically data collection has to be purposeful and informed, identifies problems, issues, and risks.
So what is data collection? When do we collect data? When we do what?
When we do admission.
Identify
assessment.
problems, issue, and risk.
So when we do our head-to-toe assessment, subjective, objective
Head-to-toe.
data. Okay. All right. So planning, put it into your own words. I know it says use knowledge to tailor approaches based on circumstances. Put it in, paraphrase that, restate it. What does that mean?
Using the
It's
data that
basically
we
just
collect.
using the data that we collect to plan for their care.
Exactly. Implementation.
Applying critical thinking about
Applying critical thinking to prioritize what's most important. What's, how many things should we be doing? Is it just will it just require this one intervention that's pharmacologic, or do we need, non-pharmacologic and pharmacologic planning for this person? So implementation. What is that?
putting the care plan in action, using clinical adjustment and spirits and ethical guidelines.
Doing is what we're doing. It's administering those medications. It is changing that Foley catheter or inserting that Foley catheter. It is obtaining that intake and output, measuring that temperature, that blood pressure. Okay, what about evaluation?
Evaluation is basically seeing if whatever we implemented is working and if we have to reassess at that point.
Got it. We gave Tylenol for the fever. They're still running a low-grade fever. Do we need to notify the healthcare provider who's giving it, as directed? The healthcare provider, a lot of times they'll go in and give another antipyretic, or they'll say, hey, just recheck recheck the temperature. So yes, evaluation is what we did. The information that we gained over here by collecting data, the subjective and objective data, and we planned for this person to be a febrile. We administer these medications. Did it work? All right, good. Critical thinking. What are these steps? What are the steps? Tell me, what are the steps as we transition here? I'm listening to you. What are the steps to critical thinking?
Collect the data.
Okay.
Identifying the problem.
Okay.
Using evidence-based practice.
Evaluation.
Mm-hmm. Keep going.
Testing it out.
Okay. Did we get all of them? There you go.
Wait, Jesus.
Okay. All right. So I'm trying to pull up this other. So critical thinking, we have to collect the data. Remember, I didn't hear verify it. And we're going to cover this again when we go over the other slides here. We want to verify because information that you have collected, is this information that we really need? Is this real information? So we want to verify it. And we want to do all of these things in an organized way. So we want to collect it. We want to verify it. And then in order to verify, we do have to arrange it to make sure that we have not missed anything, because we want to look for gaps in information. Remember, I talked about going back to 3 shifts and looking at information. Well, we have 3 statements here, but there were 4 people. So we laid the information out. Well, we've identified that there's a gap. We need an additional piece of information. Then once we have everything, we want to analyze it. What is this information telling us? And then we want to test it out. Test it out. Okay. All right. So we should have we're going to look back at these slides just so that we can make sure we're on the same page here. So, all right. From the current slideshow. Move this little thing out the way here. From the current slide. So we talked about lineage. When you hear the word lineage, you all told me that one word would be culture to help you remember what lineage was focused on. And then for generic and professional, generic, we're mostly thinking about those home remedies that patients have included in their care. They've been, using them for, passing them down for years and years and years. And as long as it's not causing them any harm or us any harm, we try to implement or include, or at least have a discussion about those things. Okay. And we talked about the preservation and maintenance, incorporating those things. And I haven't seen bloodletting or heard about it in a while, but that is something that is used. Putting Vicks on the cheek instead of the nostrils. These are different alternatives. So the patient might want the Vicks, that salve, that cream inside of their nostrils, because that's part of their culture and they have used it and it has helped. But we might want to encourage them to put it on the cheek instead of inside of the nostril. So we're still incorporating those things that are important to them, important to their culture, but we're trying to use it in a safer manner. And then those things that we need to repattern or restructure, the putting those cleansing pads instead of mud on the umbilicus. These are things that in the past they have worked. That's what they do as part of their culture. So we want to encourage, just to start shifting and changing to do things a little bit different. And that's, that comes, we also have to reinforce that education. Put it in a way that people can understand it, allow them to ask questions, and then they're more likely to buy into the changes that you're trying to implement. Okay, we talked about the 4 phases. This little bar here. So orientation, helping the person recognize the problem. The client starts to understand what the situation is. This is really important. It's important that I manage my blood pressure. It's not okay that this glucose number is 400 and that I consume all these carbs and I don't have this nice balance between diet and exercise. And then the client realizes and starts to depend on us for that information, and they start to start thinking it through. Well, hey, instead of me consuming a regular drink, I can do maybe a zero or use water with some type of fruit or something in it. So they start exploring the different possibilities of the different things that they can do to manage the disease process. And then resolution. Patient says, oh, I have it. I've been checking my glucoses. I've been walking a little bit. I've been reading those labels, and I got it. I'll call you if I need you. So they essentially end that relationship with us, which is good because they're taking ownership. So we talked about aura. We said self-care goal that is directed toward a safer environment, for everything, life, health, and well-being. Self-care deficit. Personal care does not meet the therapeutic self-care demands. They need that assistance. And then, but the nurses empower the client through the different relationships, identifying those resources that they need. And then reinforcing that education about, hey, it's important that you work with therapy because we want to get you back to your norm or as close to your norm as possible so that you can be independent. Okay. We talked about Rosenstock. Person, they don't believe, if their perception is, well, hey, this is not important, then they more than likely will not take part or action in the intervention that you're trying to implement. But again, we want to make sure everybody have enough, we want to assess their understanding of what's going on, because it could be that they just don't realize, the importance or what it is about that disease process and how to manage it, how that they can prevent complications. And then once they have enough information, if they still do not believe that the intervention that we're trying to implement is important, then we support their autonomy. We talked about critical thinking. It's based on the nursing process. Uh-oh, pick that little pencil. Uh-oh. It's based on the nursing process. We talked about gathering that data, subjective and objective data. Planning. What is it out of all the things that we assess? They're more than likely the RN, we're collaborating, coming up with the plan, the nursing diagnosis. And then we can order those based on priority. What are we going to do about this fever? What are we going to do about this dressing, this person that has this wound? Are we going to actually do the dressing changes as directed? Are we going to provide that respiratory care? Respiratory care can include measuring respirations, listen to those long sounds, administering inhalers, and evaluation. Does it work? Is it working? Do we need to go back and come up with something else? Do we need to add, or what's the goal myth? Watching my time here. We're almost at the bottom of our second hour. Let's move forward. I don't know what to do with this little bar, you all. Okay. We talked about collecting critical thinking. You do need to know these steps in the order. Collecting this data, that helps us to make sure that we have not forgotten anything, that there wouldn't be no gaps when we arrange it. We want to verify the information that we have is really correct. We want to have statements from people or information. We're looking back at the MAR to determine if a medication was actually given and there were some omissions. Well, did the patient really give this medication? For example, if it's a narcotic, and how would we verify that? On the original MAR, medication administration record, there's an omission. The nurse, for some reason, didn't document. But the nurse was like, oh, I gave all the medication. What's another way? What's something else that we can look at to verify that that narcotic was given?
The narcotic count.
The narcotic count log, exactly. And so that's another. But some medications, we can't do that. But if we want to arrange it in an organized way so that we can look for trends, look for any gaps and want to analyze it and then test it out. All right, so think about this, the different cognitive thinking levels, and then examples. Knowledge is just recalling or remembering the information. Remember, we're in skills lab. We had to remember the steps to drawing up insulin, the steps to setting up a sterile field. Okay. And then we had to do our checkoff. Then we actually went to clinical. We actually set up the sterile field. We did the dressing change. We brought up the insulin and we administered. And then the analysis part, we actually did some teaching. The patient's a newly diagnosed diabetic. Not only did we do the finger stick, we brought up the insulin, we administered, and then we explained, reinforced the information, the teaching about why it was important to do those glucoses and take the medication as necessary. So these are some examples. Knowledge. Well, what is a normal potassium level? So when we're receiving the phone call from lab, they're calling, reporting. Patient in room 201's potassium is 5.5. What does that mean? Is it okay? So high or low?
High.
Okay. So, but we got to go back to our basis. What is the norm? Okay. Comprehension. That's when we start to say, well, wait a minute. What does this number really mean? And then what do we do with this information? And of course, we report into the healthcare provider. What care should we should be providing for our patient? And how is the care that we're providing, how is it impacting our patient? Are they getting better or are they getting worse? Or is it the same? Okay. So formulating that clinical question, we want to be objective and concise so that there's no gaps or any, gaps in the information that we're looking at. We do want to use the latest information. Usually don't go back more than 5 years because that's going to be the most relevant information that we should be using. Okay. And then this Using critical thinking skills. Move us out the way so we can see this one. The gathered evidence is combined with the clinical experience and the client's preferences, that culture, and values for use in specific clinical situations. We will, adjust it based on, that. And this is just another way of looking at the evidence base. We need our information, and what guides our expertise is that evidence that's been gathered through research. How do they know that 325 milligrams of Tylenol is like the usual dose, for pain or fever, because of the evidence. The evidence has shown that. And then we do want to include the patient preferences. Sometimes patients will decide not to take medication or whatever the intervention is. Well, but based on their cultural beliefs, it's okay. We do want to include that in there. So when we're looking at research, the National Institute of Health is the entity, the organization, the body that guides research. So we have qualitative and we have quantitative research. So qualitative, we are gathering information via some type of conversation. We actually sit down and call them focus groups. You sit down and there is an interview. There are guided questions. And that interview can be in person, it can be Zoom, it could be filling out this questionnaire and returning it to the scientists. But we're gathering information in through an interview. There isn't a quantity to it. So it's based on this lived experience, that patient's lived experiences. Some examples could be, we're sitting down talking with patients that have diabetes. Are they experiencing pain? How do you manage your diabetes? What things did your doctor prescribe? Did you, in addition to medications, did your doctor prescribe non-pharmacologic agents? Did they prescribe a walking program for you? Did they include exercise in that? And it's just information gathered through a conversation, whether that conversation is verbal or they have to write it down and return the questionnaire. Quantitative research is where we're gathering things that are measured. So that would be height, weight, that would be blood pressure measurements. It could be an EKG reading, an echocardiogram. That's where they get the ejection fraction, how well that heart is working or what percentage is there. But quantitative is a number. You're getting some type of quantity or measurement is how you can kind of just remember that. So let me hear from you. Come off mute. Tell me some responsibilities of the charge nurse. And this is going to take us to our next little break. What are some, you're getting ready to be this charge nurse. What are some responsibilities that you're going to have?
Handling prioritize client needs.
Okay.
Medication administration like heparin, insulins, like those high priority medications, blood back stuff.
Keep going. What's some more responsibilities of you as the charge nurse? This is what you're getting ready to do.
To delegate tasks.
Okay. Delegate. What helps you to delegate? Remember those rights. But we're going to have to prioritize that client care. What kind of care does this patient need? Do they need one person, two persons, assistants? What is it that they need? We're their first line manager. But remember, we need to prioritize their care, determine what that client's needs are, and so that we can appropriately delegate. We have 1 minute. Tell me about the spirit of inquiry.
New nurses, they come up with different plans, different ways of doing stuff, asking questions.
So it's not a bad thing. And what the spirit of inquiry is, usually we see it in the new nurses because you all have that latest information. You are writing your papers and you're using the whatever year it is, you're not going back 5 years. So you all have the latest information. And so that spirit of inquiry says, hey, can we accomplish this same task, this same goal for this person, our patient? Can we provide the best care we can by doing it different? Can we use less resources? Can we use less time? So that's that spirit of inquiry. We raise questions, challenge traditional practices, and we see creative approaches. All right, so I'm gonna stop sharing here. Let's take another break, 5 minutes, and we'll save our last 15 minutes for the end. Remember, you can turn your cameras off, but it's still being recorded, so make sure you're on mute. All right, come on back. We let's say about other minutes toward the end, but we was talking about the spirit of inquiry. You usually see it in new nurses. That doesn't mean you can't see it in younger, older nurses or seasoned nurses. But the whole thing about the spirit of inquiry is we are trying to see if there's a different way that we can take care of this patient with, if not the same, better results. And so using less time. And so you may be called to work in on the policy committee, because if they have to look at policies and make revisions to them, of course, based on the Nurse Practice Act. But this is where you're able to, make those recommendations and explain, how we could do it differently. So official government healthcare agencies, how the services that they are providing, how are they providing it? Who pays for it? And then what type of programs are out there that they can implement? So, of course, it's usually supported by tax money. And then the primary service is disease prevention and health promotion. So, what level of intervention is that? Disease prevention programs and health promotion. What level of prevention is that? Primary. And so that's usually their basis is preventing, diseases. And then they provide those direct services. There's so many programs, and they're non-mandated programs, and they also have those mandated programs. But there are so many that can assist with, I think one, like the summer's coming, so they have like this water campaign where they're trying to, keep everyone hydrated over the summer, because the months are coming, the weather's going to be warmer. So they have these campaigns and this information. They have these radio announcements. They have these billboards and things, and so they are giving out water bottles. They're giving out what are those little things? Those things that you can place in your water. Just encouraging people to stay hydrated. So again, the state does use funds to help pay for these programs. They may receive some federal government money, and the state can decide whether or not they want that money or not from the federal government. Okay, so we do have the United States Department of Health and Human Services. I believe that does still exist. Not sure if it exists as its traditional sense, but it's there. Excuse me, and it's the funds that pays for that. This federal fund. The president appoints who's over that agency. Like I said, there are some revisions going in these different programs now. So what does each do? What is the Center for Disease Control? What are they all about? What do they oversee? What about the Food and Drug Administration? You can come off mute and tell me. Let me go back. So the Food and Drug Administration, remember, they're the entity, the body that makes sure that our food, our medications, and our devices are safe for us to use. Making sure that our foods are safe to eat, our medications. And the Centers for Disease Control, they're one of, when we say report things to authorities, the health departments, the Centers for Disease Control is that body that information goes to. So they oversee, and they put out warnings or notices to let states know, well, hey, we're seeing an uptake in influenza, or they're telling us what they're seeing, and it comes from that reportable disease list. But it's all about health promotion and preventing diseases. Okay, and so we have our non-official public healthcare agencies. They're supported by contributions. Their primary service, research and education. We have our private healthcare agency. These are fee for service, and it is what it is. If you want a service, For example, if you want an MRI or lab work done, there's a fee. You pay for it and you can get it done. That's fee for service. So for these nonprofit hospitals, you all, community hospitals, their funds usually comes from donations, mostly religious organizations and other community organizations. It does not mean that you have to be that religion in order to go to that community hospital to receive services. It does not mean that you have to be a part of that community organization in order to go to that hospital to receive service. It just means that this is how the nonprofits, this is how their bills are paid, their staff is paid, the supplies that they buy. They rely on these donations from these community organizations and religious organizations. But the same standard of care must be followed. It's just saying that's who pays their bills. They're not in the business to make a profit. So they're supported by other entities or bodies to help pay for their oversee their budget or pay for their budget.
So with the nonprofit, they don't have to be the same religion as
Nope.
whomever, and the donations come from gifts and donate. The funding come from donations and gifts.
That is exactly what it means. Their funding comes from gifts, which are donations. Exactly. That's all that means. But the same care, anyone can go there and receive those services. So home health, remember, we're not there. We're just providing that intermittent care. We want our patients to be as independent as possible. There should be communication between the person's getting discharged from long-term care facility or the hospital. There should be communication between that facility that they're leaving and the home health nurse. And we can provide skilled care. Remember the Omaha system. I don't know if this is on a slide, but home health care requires, and I don't know if you all have did a home health rotation, but there's a lot of documentation that is required for home health. So the Omaha system is just a system that it meets the specific needs of what is needed to be documented for a patient that we're going in to see in their home. And they've checked all the boxes. So that's a system that the home health, even though they have the electronic healthcare system, they have decided to follow the format of the Omaha system. And therefore everything can be addressed that is needed because if those things aren't documented, then this person more than likely is not going to be able to or eligible to continue to receive home health. And so, but home health, the client can receive all of these services as though that they're in a facility. They're just doing it in the comfort of their home. They still get that skilled nursing care, physical therapy. They still are able to receive all of this. But that Omaha system helps us to document everything that is needed, that is required. So medically necessary care to improve health or maintain or slow decompensation, that skilled nursing care. So after a major surgery, we're trying to get that patient back up and walking. Think about those activities of daily living, bathing themselves, getting back, able to feed themselves. We want to get them and being able to administer their own medication. But initially, of course, we're in and we're reinforcing that teaching, and we are there for them, to assist them till they get back to their optimal level of care. So here it is. This was on a previous slide, those duties that we had. That was as a charge nurse, but here it is all together, our primary duties. Where just think about those things again that you got checked off on the skills lab that you are doing in clinical. Finger sticks, administering medications, treatments, oxygen, you're applying that nasal cannula, you're making sure that it's set on the correct rate. You're reinforcing teaching. Just think about all those things that you're doing. So we do need to know hospice and palliative care. The goal is to maintain comfort as death approaches. Usually they have been certified and there's a statement written that death is pretty much imminent within maybe 6 months. I think that's the time frame, 6 months. But I've known several people that was written, they were certified, they had a terminal diagnosis, and they didn't pass away within that 6 months. And so, but that's just the prognosis of it. And so that they can receive a different set of services. And hospice can be provided in the home, or they can be in a skilled nursing facility. They have nurses that come, they have the unlicensed personnel that come, they provide the supplies that they need. And they actually have their own set of everything, their own doctor and everything. But it's just, and they even have a person of faith, clergy. So they address the whole person. Okay. So hospice, the goal is to maintain comfort and dignity. Okay, they do have those inpatient hospice care, and some of those are located inside of the hospitals. It's just maybe on a different floor or in a different building. And of course, they can be in the home, like we mentioned, and also at the skilled nursing facility. Palliative care, maintain comfort at any stage in the disease process. Remember, hospice is toward the end, and then palliative care is at any stage. Okay, they do not have to be written up as terminal in order to receive that palliative care. Now, a person under hospice, like repeated lab draws, like every 3 months, so things like that are going to be a little bit different for a person that has hospice care rather than palliative care. Yeah, more than likely they're still going to be getting those routine labs and the dentist coming in or seeing the foot doctor and things like that. But under hospice care, those services are going to be different. So wellness center. What kind of clients would we refer or would be referred to a wellness center? What kind of services do wellness centers, what do they provide? So we have someone that's newly diagnosed diabetic, newly diagnosed hypertension. So more than likely that doctor's going to write for them to go to that wellness center so they can get that nutritional, that one-on-one about why it's important. What is this food label mean? Why is it important to look at this label to identify the number of carbohydrates, the number of sodium, the amount of sodium that's in this meal or this drink or this food item? And so the wellness center is a good prescription or place for people to get that one-on-one. They incorporate those exercise programs that's needed to have that nice, well-balanced regimen. So community health services, best for the client in need of. We have education can be groups or communities. And the focus is on prevention. So what is our role as that community health nurse? We wear so many hats if we're in the community. We're the advocate, the caregiver. We might be that school nurse, that occupational nurse. And these are just some locations. The adult daycare, a person that is needing total assistance. The adult daycare is not the appropriate setting for them. A long-term care facility or a skilled nursing facility would be appropriate setting for them. But the adult daycare, and we're seeing where they have the night part as well. And so clients are usually, they go and they stay, for whatever amount of time. It could be the entire time that their loved one, their child or spouse is at work. And then, they're there, they have all different activities for them to do. A person can use a cane, walker, or crutch, but adult daycare is not the setting for someone that's needing two persons assistance or total care. You do see those adult daycares there. You're seeing more of those facilities. So be able to identify the client that would live in each facility. So independent living with a person that needs total care, should they be living in an independent living facility?
No.
No.
Okay.
It'd be in the long term.
Exactly, long term. A person that's total care shouldn't even be in an assisted living because it is what it is. It's saying that they need some assistance, not total care. For the most part, the assisted living, they're pretty close to independent, but there are nurses. This is a setting that you can work in, but you won't be doing skills like inserting Foley catheters. Rarely do you do that in assisted living facilities. You may just do some check-ins or go through their pill tray or whatever with them, but for the most part, you just providing that minimal assistance. So someone that's needing total care would not be in that facility because that is not the level of care. The level of care that they need will not be provided in that setting. Okay, so the family through the eyes of Alzheimer's. So we here, this is just getting you to see what the family they see. They see their loved one, that the outside, but then that loved one might not remember who they are. So they may be calling you, the nurse, their child or their daughter or son, and their son or daughter is right there. And so that can be that can put them in a not so easy place. They're seeing their loved one, but the things that their loved one is doing is not their loved one. So silence is always appropriate. Just being present, it is therapeutic. And so depends on the stage of the Alzheimer's. Early onset, that this person can still be independent at home, but advanced, this person might need to be in a skilled nursing facility where they receive the around-the-clock care. So the purpose of the Affordable Care Act is in the title, to make healthcare more affordable. That was the purpose of it. And so to minimize cost barriers, to give people an opportunity, it wasn't like a one size, everyone has the same insurance. It just had like the marketplace. There was a variety. So in the event that you had insurance, but it wasn't enough, and also if you didn't have insurance, it gave you the opportunity to be able to purchase insurance coverage that was affordable. I don't know, for those of you that that have like the employee insurance, if you look on that stub and see how much that insurance would cost in the event that you're paying for, insurance is expensive. And so here we kind of talked about this already. Fee for service, you need your lab work done. You can get that lab work done as long as you have the money to pay for it. So whatever that fee is for that service, as long as you have the funds, the money, the way of paying for it, then you can have that test, that MRI, or that blood work, whatever it is, done. So we do need to know what the deductible is. The deductible is that yearly amount of insured that the insured person must spend out of their own pocket before the healthcare insurance policy before they begin to pay their part. So you have two people paying for this insurance, but the person that subscribed to the insurance company, we must pay out of our pocket whatever that amount is. Sometimes it's $500, sometimes it's $1,000. Whatever that amount is, we must pay the person that has subscribed to the insurance before that health insurance company pays their share. Think about it. For example, motor vehicle insurance. If you need some type of repair, maybe it was in a wreck or something like that, that amount that you must pay out of pocket before the insurance company pays their part. So you do need to know that these are public health insurances. These are examples. Veterans Health Administration, Medicare, and Medicaid. Now, private insurance, thought that was on the next slide, is like your Blue Cross Blue Shields, your United Healthcares. But the public insurances are these three right here: Medicare, Medicaid. Medicare, what's the age for Medicare?
65.
65.
And older, yes. And Medicaid is based on income. Veterans Health Administration. So those are the public health insurances. You do need to know these different parts. So this is public health insurance. We take 65 and older, and the different parts. You need to know which part pays for what. So we have Part D, our medications or our drugs. Part A and B, one is inpatient and the other one is outpatient. So inpatient is A. So that's in the hospital, skilled nursing facilities, and then Part B is going to the doctor's office, so that outpatient care. And then we have Medicare Part C, offered by a private company that contracts with Medicare. Medicare Part C is offered by a private company that contracts with Medicare. So can include HMOs, PPOs, fee-for-service plans. It also can include paying for that medications as well. But usually D is the part that pays for meds. Part C is that private, offered by those private companies, and they contract into Medicare. So it's part of Medicare, but it's really not part of Medicare, but it is. So that's that Part C. So A is inpatient, B is outpatient, D is medications, and then we have C is that private company. And I'm trying to think of I know like phone service, this may not be a good example, but you have like Verizon's, your T-Mobile's, all these different phone carriers, but they say that there's really only 2 or 3 really main carriers. All the rest of the carriers subcontract to those main carriers. So I don't know if that was a good example, but that's what this Part C is. So they're offered by private companies, but then they contract with the Medicare. So it is up to the person to subscribe to whatever they would like. So we have Part B, outpatient. So ambulance transportation. Who pays for that ambulance ride? That's Part B. So in that service has to be documented that it's needed. Ambulance ride one way can cost a person $2,000. So if the documentation is not there that supports why this person needs to ride in an ambulance to go wherever they need to go, then that person will receive a bill. Part B will not cover it. And so you see it a lot of times. You're seeing it trend now where a person has a medical emergency, so they ride to the hospital in the ambulance. But once they get stable, they need to find a ride home. The ambulance can take them home, but it's post a $2,000 bill. But we need to know that B pays for that ambulance transportation. It's things on the outside, outpatient. Okay. Medigap. It is what it is. It stands in the gap. So it takes it assists with coverage for all of these things, where those other insurances, don't pick up. Because usually when you go into the doctor's office, they ask, is this your primary insurance? Do you have any additional insurance? So is there something that stands in the gap? Okay, we talked about who is eligible for Medicaid. It's based on the income. Adults on disability under 65. It does vary state by state because it comes from some of those state funds. In federal funds, if the state decides to take part in it. So we do have the CHIP program. It is free or low-cost health insurance for children up to age 19, and it does fall under that Medicaid program. So a child might not qualify for Medicaid because the parent or guardian's income will disqualify them. But then you have CHIP. So if the person makes maybe $10 over, $100 over, or $300 over that disqualifies them for Medicaid, you have CHIP. Depends on the amount over. It might be free, but for sure it is low cost. Okay, so uninsured. There's a lack to access to healthcare. They use the emergency departments because remember, the doctor's office, they want your insurance card. They want that copay before you even go past the desk. So most of the times we see if we're uninsured, we're going to the emergency department because they will ask you, but they're not going to turn you away. They will still go ahead and treat you. And so, and usually they seek treatment late in the disease process because they are putting it off more than likely, trying not to go because they know that insurance is a real thing. That's where that affordability came in. to make insurances more affordable. So someone that's uninsured or even underinsured, more than likely they're going to seek that health care in the emergency department. Then they're going to be late in that disease process because they would have put off receiving that health care. Now, who are these DRGs? These are, it is a formula. It's the amount of money that is going to be paid for whatever is going on with that person. They're diagnosed with high blood pressure. They're diagnosed with the right hip fracture. These diagnostic related groups has this gigantic book, so to speak. And what they say is, hey, this is the amount of money that we will give you for this diagnosis. Okay. Right broken ankle, or high blood pressure surgery on gallbladder. This is the amount of money that we will pay. So that is guaranteed reimbursement, but that is why documentation is so important, because there's so many times when people go in to get a surgery done or to go in to receive a certain amount of health care and other things happen. So that documentation is going to be your supportive data so that that facility or healthcare provider can receive reimbursement. That's what that documentation, another reason why that documentation is so important, because otherwise they're going to just get that flat fee for that initial diagnosis that they have. All right. And so I know we have not taken our last break. I do want to be good stewards of your care, so you're free to log off. I'm going to stay on a few minutes just to cover the rest of the content, but I'll upload this and share this just as soon as it is available. Have a good night. Next week is exam week. Make sure that you have your IDs. Download your exams prior to coming. They're open at least an hour before. Think about if you need that exam proctor. What are some other tips? Make sure that you attend the exam reviews. Commit to going back through your classroom recordings and the exam review recordings. Have a good night.
Good night.
Good.
Thank you.
You're welcome. Take care.
Dr. Ford, I got a question for you when you get some time.
Okay.
I have something too to say, if you don't mind.
Okay, so we'll
Can
need
I
to
go
go to
ahead?
the break. Hold on, we'll need to go to the breakout room because remember these sessions are recorded, y'all. So hold on.
Okay. Okay.
Hold on. Hold on. Let me stop it. All right. So now let's just wrap it up. All of the information that we have covered. So use your clinicals as an opportunity to establish those professional relationships with your mentors, doing those clinical rotations, and regularly engaging in professional development workshops that will help advance your nursing career, help you to identify your strengths and your weaknesses, and then identify resources that you can utilize to improve upon and advance your nursing career. So when we're networking in an organization we are just getting onboarded. So what happens is when we go to apply at a facility and we get hired, they're just trying to onboard us. But once we get in, we need to continue to network. We need to ask if are there any additional benefits the organization has to offer. When we see if there are any committees that you can actually participate in, the ethics committee, they usually have a what's the committee? I forget what it's called, but a PR committee, public relations. So they have events If the community is having events, you would be the person that will go to that event and represent that organization. So see if there are any committees that you can participate in, and you can assist others of the healthcare team without being asked. And when you do that, don't assume duty. Just, assist with things like maybe changing the trash out, refreshing their water, or things like that. So when we're creating a resume, we do want to use that balanced design. We want to limit that resume to no more than 2 pages, and we want to use those bullet points when listing job skills. Okay. So you as a student nurse, be keeping up with your clinical rotations, because you can include that information on that cover letter. You can highlight your academic achievements and their clinical rotations that you had. Because, initially you will not have any experience as a nurse, but you have experience as a nursing student. So that's why you want to include those information from those clinical rotations. So you do want to send a thank you email and then tell the interviewer that you will follow up with them at that specified time before leaving the interview. It is considered illegal to ask any health related things, like if they want to know how many times have you had surgery on your arm, or have you had hip surgery. It is illegal for an employer to ask about past or current health status. Asking about qualifications that apply to the position, such as licensure, education, and overtime availability, those things are acceptable because that is directly related to the job. Using the STAR method, which is situation, task, action, and result, it helps you have a structured response when you are asked to describe or communicate in such a way. They ask you a question. So using that STAR method, it helps you to communicate effectively during that interview, so that it helps you focus on what was the situation, the task, the action, and then the results. Because many times they will ask you to give an example of something. And so that will help you. That method will help you communicate effectively. Okay. We talked about the U.S. Drug and Food Administration is responsible for ensuring that foods, human and animal drugs, biological products, and medical devices, electronic products that emit radiation are safe. But that's the U.S. Food and Drug Administration. That deductible is that yearly amount that patient must spend out of pocket before the insurance company start to pay their part. Talked about DRGs, is that formula the government uses to calculate what is paid for each diagnosis, right hip fracture, toenail removal, whatever that diagnosis is, it is a specific amount of money that the insurance company will pay. Diagnostic related groups. The Affordable Care Act, it was created to decrease the number of uninsured people in the United States. The whole idea was to improve the affordability of healthcare, just make it more affordable. So expanding access to healthcare is crucial in reducing healthcare disparities, because it's not that people don't want to take care of themselves, but if I don't have access, if I don't have a hospital or a local healthcare provider to go to for those preventative services, then how am I able to take care of myself? So expanding that access to healthcare, it is crucial in decreasing or reducing healthcare disparities. So the Joint Commission on National Patient Safety Goals for the hospital setting Examples are improving the effectiveness of communication between the caregivers, using a universal protocol for preventing wrong site, wrong procedure, and wrong person surgery, identification of safety risks inherent to the client population, and improving the accuracy of identifying clients using 2 client identifiers. These are those Joint Commission national patient safety goals for the hospital setting. So now let's talk about those national patient safety goals for that long-term care facility. That is implementing fall precautions, using aseptic sterile technique to insert that indwelling catheter, reposition a client every 2 hours, implementing the rights of medication administration. So a never event are serious and highly preventable events such as hospital-acquired infections. A sentinel event is an unexpected occurrence involving death or serious physical injury. An adverse event is serious, undesirable, and usually unanticipated patient safety event. But a never event is highly preventable event. And an example of that is a hospital-acquired infection. So a person goes in for hip surgery. It is not expected they end up with some type of infection. That is considered a never event, a hospital-acquired infection. Implementing standardized care protocols. Standardized care protocols help in decreasing variations in care, which can lead to improved safety and efficiency. So implementing those standardized care protocols will help with that. Okay. So in order to enhance patient safety in the healthcare facility, they will have that regular scheduled staff training on new equipment. They have implemented electronic health records, and I think that's everywhere. That's been like a law for a couple of years. They have patient-centered care teams, and then periodic review and revisions of treatment protocols. To improve the quality of healthcare, the nurse can obtain certifications, participate in continuing education and quality improvement, and incorporate the aims of the Institute of Medicine into practice. Again, remember those Joint Commission national patient safety goals for the hospital setting and also for the long-term care facility. Make sure you review those. Remember the different parts of Medicare. A is inpatient, B is outpatient things. For example, B would be to cover that ambulance ride. So remember, uninsured individuals, those that do not have insurance, usually treatment is delayed. So you usually would see them advanced. If they have a chronic disease, it would be well advanced because treatment is delayed. And they're least likely to have a healthcare provider. And then they receive that care in the emergency departments because they're not going, the emergency rooms will not turn people away if they don't have that payment. So public health insurance, Medicare, Medicaid, Veterans Health Insurance, those are examples of public health insurance. Private pay is not health insurance. It's not public health insurance. Private pay, it is what it is, private pay. Those are examples. An example would be like that Blue Cross Blue Shield. That's that private insurance. But Medicare, Medicaid, and Veterans Health Administration, those are those public insurances. Medigap, it stands in the gap. It covers those co-payments that Medicare does not cover. Medicaid, the person has It's an adult that has disability that are under 65. The Medicare is those that are over 65. And Part D covers those medications, and it can be purchased through an approved insurance company. That Part D can. So if a patient wants to know how they can get Part D, they can purchase it through a additional and add that to their plan. So the Affordable Care Act, they eliminated those lifetime coverage limits. So if you have that pre-existing condition, it eliminated those lifetime coverages. Prohibition against denying coverage for pre-existing conditions. And then it reduced drug costs because medications are really, really expensive. So the benefits of Affordable Care Act, it made that healthcare coverage more affordable. People had a selection. They could go in and decide what they wanted. It eliminated those lifetime coverage limits. So what that meant was before the Affordable Care Act, you could only receive services up to a certain amount of money. And that was it. You could get the services, but then you were responsible. Then it did away with pre-existing condition. So in the event what a pre-existing condition was, if you had a disease process, high blood pressure, and it was on your record. So any medications, any treatment that's related to that high blood pressure was considered a pre-existing condition. So you were denied coverage. So what that meant was you could get the services, but then you had to pay for those. But what the Affordable Care Act did was it eliminated that penalty for having a pre-existing condition. That Affordable Care Act, it really, the whole purpose was making it more affordable, and then it decreased the prescription drug costs. Now, can we fine tune it? We probably can, because medications are still really, really expensive. We talked about the ways of thinking. Application means to be able to use learned material in new situations. Knowledge is referring to recalling or repeating information that we have memorized. Comprehension refers to understanding the information and recalling it. So if we were able to, we practice a skill in the skills lab and we went to clinical, and then we actually performed whatever that skill was. So we practiced medication administration in the skills lab, but we went to clinical and we actually administered those medications. So that's an example of application. We talked about the spirit of inquiry already. We say the spirit of inquiry refers to one who will challenge traditional and existing practices. That's raising those questions and seeking creative approaches to problems.